So let me introduce me. My name is Alviggi, and I work in the south of Italy, in the city called Naples, where I invite you, all of you, next year for the third edition of World Congress of Gonadotrophins, and in particular LH in ART. So I don't know if I've been in Naples before, but I strongly suggest to come here for having a nice meeting all together. So I will address many points. I will try to deliver appropriate messages that we can share in the discussion later. But I decided to give this general title, which is choosing the appropriate gonadotrophins, meaning appropriate regimens for patient. I'm talking about matching patients and protocols, because personalization is very crucial at the moment. In the next slides, you will probably see my disclosure, nothing more. So can I ask you next, please? Okay. So the first, so we can go directly to the next one, obviously. Otherwise, I have to comment my disclosure, but I think that is very annoying. So probably better to go to the next slide.
Okay, sorry, one technical problem.
Okay, this is just to say that when we talk about any kind of treatment, and in particular IVF, we have to distinguish between efficacy of the treatment, meaning the capability of a given treatment to give a given results. For instance, in our field, I think that the ideal endpoint is cumulative live birth rate, but something different is the efficiency of the process. Because we can have the same efficacy, but we can have less or more efficiency. And so efficiency is something related to the risk of complication, cost-effective analysis. So everything that contributes to having our result. And I think that in terms of efficiency of a given protocol, treatment, or approach, what is crucial nowadays is time to pregnancy. So we have always to keep in mind that even in presence of the same results, the time we need for having that results is the main aspect related to efficiency. I like to start with this slide because some procedures seems to be probably not necessary, but if you consider that this approach can improve time to pregnancy, they make sense. So if I can have the next slides, I would like to start with this slide, because this represents what happened in the last 20 years. Now, I think that at the beginning of 2000, the idea was that we had only few protocols for treating patients: agonist long protocol, agonist short protocol, antagonist. And so we matched patient and protocols in a very easy way, but with not so much possibility of personalization. What we understood in the last years is that we can stratify patient according to ovarian reserve. So we can have a patient with a good ovarian reserve, meaning anti-Mullerian hormone or follicular count in the range of normality. And so we call this patient good prognosis patient. We have a patient with higher ovarian reserve that probably have a higher risk of complication, including OHSS, and low prognosis patient that we usually identify with the poor ovarian response, meaning a patient with a very low ovarian reserve. And this was the system up to until a few years ago, where the key word in good prognosis patient is, in my opinion, efficiency, the best cost-effective approach. In high responders, the key word is safety. Safety has to drive our decisions. And in low prognosis patients, probably compliance and cost-effective approach are the key words. So I will focus the first part of my talk on good prognosis patients. So if I can have the next slide, you will see an animation here. Go fast to the next slides, if it is possible. Okay, let's move. This is the most famous slide probably in the last years that showed for the first time two very important kinds of information. The information derives from retrospective analysis of 500,000 cycles. So despite the retrospective, the sample size is incredible. And what I would like to say that this information is only related to fresh cycles, and it is very good because it's related to live birth rate. This is an endpoint that we really appreciate. And what Sesh-Sunkara demonstrated is that the more is the number of eggs, of oocytes, the more is the chance to have a pregnancy in IVF. This is up to 15. In fresh cycles, if you overcome 15 at any given age, you will have stable results. You will only increase probably some risk, some discomforts and complication. But this is only in fresh cycle. If we go to the next slide, I'm afraid that the next slide is full of animation, so you probably have to click many times, forgiving me, but do it. And so sorry that we have these problems.
One technical problem again. 1 minute, please.
No problem, no problem. So I take the opportunity for telling you I can anticipate what's going on. I will show you that another group in Brussels is a very famous group, demonstrated the same, that if you stratify a patient according to the number of eggs, increasing the number of eggs, you will have a higher chance to have a pregnancy. So if you go until the end of these slides, so please move animation if it is possible. And you will see that if you consider another endpoint, which is the cumulative live birth rate. Cumulative live birth rate means that we are including not only fresh cycles, but also pregnancy deriving from frozen embryo transfer. You will see, this is the last line, cumulative live birth rate, that even above 15 eggs, the result will continue to improve. So in fresh cycle, up to 15 eggs. But if you consider cumulative live birth rate, if I can have the next slide, I will show you something very intriguing that has been recently published by the group of Nikos Politsos in Barcelona. And you can see that again, in fresh cycles, this represents the fresh cycles. The best results are up to 15 oocytes. If I can have the animation, the next click. You can see that if you consider the cumulative live birth rate, even up to 25 oocytes, the more is the number of eggs, the more is the chance to be pregnant in cumulative live birth rate. So in the next slides, I will show you the reason why. The reason why is very easy. If you adopt controlled ovarian stimulation, if you increase the number of eggs, you don't modify the rate of aneuploidies. So if you have 5, 10, or 15, or 20 eggs, the rate, the percentage of euploid and oocyte and obviously blastocyst is always the same, the rate. So if the percentage, can you click for just once, please? If you have 30% of euploid embryos, or euploid oocytes, this 30% is related to age. It is not modified by the number of eggs retrieved. So if the rate is the same, increasing the absolute number of oocytes, you increase the absolute number of euploid blastocysts. And this is at any given age. So it is convenient to have more oocytes. It depends on your approach. Because nowadays, a very good approach, at least in my opinion, but it has to be personalized for any single patient, is one stimulation, one family approach, all in one. Because if I have a 35 years of age patient, the rate of aneuploidy will be 50%. So it's very high. So if I have the opportunity of stimulating these patients once, and I have 2 or 3, 4 blastocysts, I have higher chances to have at least one euploid, at least even more than one, meaning that I can do more than one transfer, even considering blastocyst for a second child if it is required. So one stimulation, one family is very good by efficiency and is very good in terms of time to pregnancy. Obviously, it is not useful to have too much blastocysts if it is not required. This is something that you have to balance patient by patient, but having always in mind, if it is possible, age, expected aneuploidy rates for any given age, and the ovarian reserve. If I can go to the next slide, this is something that we have to keep in mind, that gonadotrophins are different each other. Obviously, I'm not here to say that one gonadotrophin is better than the other. Any kind of approach can have different results. So you have to understand which kind of results you want. So this is a nice trial that has been realized in the United Kingdom some years ago. And what is important is to understand that recombinant FSH is more potent than HMG. So at a given dose, at the same dose, the recombinant FSH is able to give a better fourth, meaning a better percentage of recruited follicles and a higher number of oocytes. If you see the second slide from this trial, the next one, please, you can see that for any given number of oocytes, the FSH consumption is lower with the recombinant FSH. Is a mirror, is a specular, I can say, view of the same information. So with the same dose, you have more oocyte. With the same number of oocytes, you spend a lower doses of gonadotrophins. This is important in cost-effective analysis because we can say that urinary gonadotrophins are cheaper, but you need higher doses probably for having the same results. So this is something that you have always to keep in mind, that gonadotrophins, we all know, are different and recombinant gonadotrophins are more potent. If you see the next slides, I tried to put all together information deriving from this is the one related to those. In the next, I put it together different trials that compared HMG. I saw the slide for 1 second. So you have, but anyway, what I will show with the next slide is that all the comparative trials, including MERIT trial, MEGASET trial, all the comparative trials between recombinant FSH and HMG and highly purified HMG, all the trials are consistent in the evidence that the number of eggs is higher with recombinant gonadotrophins. This is very important to keep in mind. So if I can have the next slides, I will probably ask you to skip some slides because now I want to talk about the low prognosis patient. So if I have to give some take-home messages concerning good prognosis patient, the topic we were talking until now, the two key messages are that you can use any kind of gonadotrophins, but you have to understand that recombinant ones are more potent. With the lower doses, you can have more eggs. Anyway, having more eggs is convenient because the more is the number of eggs, the more is the probability of having at least one euploid blastocyst. So this is the key message, the key messages these are that I would like to give. Let's move to low prognosis patients. And in low prognosis patient, next slide, until now, the model that we have in our mindset is the so-called Bologna criteria for defining a poor ovarian response. And I think it was an historical attempt. I really supported this initiative because the Bologna criteria were the first attempt to try to find a common definition of a poor ovarian response. Until 2011, we had probably 40 different definitions of poor ovarian response. So the Bologna criteria were incredible in setting the scientific community on the definition of a poor ovarian response. But if I can have the next slide, just summarizing the Bologna criteria, what I would like to show you is that Bologna criteria are based on the idea that prognosis means number of eggs. And this is clear, I agree. So they have 3 criteria: advanced maternal age, meaning 40 years of age or more, previous POR, meaning history of poor ovarian response, or abnormal ovarian reserve biomarkers. According to these, you can have a 3-4 combination, because you need at least 2 of these 3 criteria for having definition of poor ovarian response. This is good, but on the other side, we found some limits in designing trials in this, because some risks are there. The first is reported in the next slide. Having so much combination, because you can have 1 + 2, 1 + 3, 2 + 3, all the 3. You run the risk of putting in the same box totally different phenotypes. So you can have a patient 35 years of age that had a previous or 2 previous POR, and you can have a patient 42 years of age. They are both consistent with the Bologna criteria, but the rate of aneuploidies will be totally different, because the 35 years of age woman, despite low ovarian response in the previous cycle, still have acceptable rates of good quality oocyte. The 42 years of age, even with the same ovarian reserve and the same ovarian response over the other one, will have 70–80% rate of aneuploidies. So they cannot stay in the same basket, in my opinion. Another problem, if I can have the next slide. The other problem is that in Bologna criteria, the cutoff of age is 40 for defining elderly patients, low prognosis patients. But you can see that even if you have a look to the first line here, the rate of euploidy in blastocysts is reported. You can see that even moving from 35 years of age to 38, 40, 42, more than 42, the rate of euploidy embryos dramatically decrease year by year. So having 40 as a cutoff probably is not appropriate, because even between 35 and 38 years of age, difference is dramatic. So again, we cannot put in the same basket these patients. And the third limit, in my opinion, of Bologna criteria is that it is not considered, next slide please, it is not considered the ovarian sensitivity to the stimulation. Because what I said at the beginning of this talk was that in the last years we understood that even with a similar demographic or anthropometric characteristic, a patient can have a totally different ovarian reserve. But even with the same ovarian reserve, the sensitivity to ovarian stimulation can be different. This is an example of 2 patients, same age, similar in terms of BMI and basal FSH, but the ovarian reserve is totally different. So probably if we use the same starting dose, we will expect the same similar ovarian response or a given ovarian response. But have a look. The first patient moved from 15 follicles, a very good antral follicle count, but only 5–7 follicles reached maturity. So only 30% of follicles reached maturity and gave probably a mature oocyte. The other patient moved from a lower antral follicular count, and at the end of the day, she had the same number of mature follicles. But in this case, the follicle output rate was very high, meaning that 80% of their antral follicles reached maturity. So at the end of the day, if I can have a next click, at the end of the day, they will have same prognosis, because the quality of the oocyte, the number is the same. And the quality of the oocyte is related to age, because aneuploidy rate are related to age. So having at the end of the stimulation the same number of eggs, this patient will have the same prognosis. But In the first patient, in a second stimulation, we can do something more because only 30% of follicles had a good response to stimulation. So probably in the next stimulation in this patient, we can increase the dose. We can move from urinary to higher dose of recombinant. We can move from agonist to antagonist. We do many things. We can do many things for trying to increase the follicle output rate. In the second patient, the fourth was very good. So we don't have to change nothing in our stimulation because the efficacy of the stimulation was very good. So probably in the second patient, the only way we have to have more eggs, which is our aim for having at least one euploid blastocyst, is probably accumulated. So if our goal is 15 eggs, the only way we have to do in the second patient is doing 2 consecutive or even 3 stimulation. In the first patient, we can probably have the same result, increasing the dose of gonadotrophin. So it is totally different approach with the patient that have a similar profile in terms of number of eggs. So the number of eggs is important, but in Bologna criteria, we don't consider sensitivity. So that's the reason why, next slide, if it is possible, that's the reason why we proposed recently a different approach. So we can go on, we can go again. And we proposed a different approach, which is called Poseidon stratification. So the aim is to consider poor ovarian response, but not only poor ovarian response, to move from poor ovarian response to the concept of low prognosis patient, low prognosis idea. So if I can have the next slide. So according to this proposal that with many friends and colleagues all over the world, and this is open. Poseidon is an open field where every contribution, every idea, and so I do invite your nice society to join us in a very active way. We can design trials together because the Poseidon community is growing worldwide. And probably you saw this in the past. So here the idea is different because patients are classified according to prognosis in 4 groups, having in mind ovarian biomarkers, meaning ovarian reserve, if available as information, the number of sites retrieved in the previous cycle, and the age. But please note that our cutoff is 35, because 35 is the moment where the rate of aneuploid is dramatically increased year by year. And in the group 1 and 2, the concept of ovarian sensitivity is there. Group 1 and 2 are patients that had at least 1 previous stimulation that moved from a good ovarian reserve, but had an unexpected poor ovarian response. Group 3 and 4, if you can go back again, are patients where the ovarian reserve is low at the beginning of the cycle. So the poor number, the low number of eggs is expected. So 1, 2 patient with few eggs retrieved, but unexpected. The 3 and 4 patient with the low ovarian reserve. On the left side, patient group 1 and 3 are patients below 35 years, and group 3, 2 and 4 are patients above 35 years. So we have 4 categories that I think are more homogeneous inside. I need your concentration. Can I go to the next slide? Sorry, I know it's very stressful for you. Next slide. I have to skip some slides because we don't have so much time. Next slide. Let me show you something in the next slide. This is an intriguing analysis that has been proposed by Sandro Esteves in 3 different countries with a huge number of observation having cumulative live birth rate as endpoint. So on the right side, you have all good prognosis patients that we can say non-Poseidon, not fitting with Poseidon criteria. In the left side, you have the 4 Poseidon groups. So altogether, the 4 Poseidon groups perform worse than non-Poseidon. The outcome was lower. But if you have an analysis of the 4 groups, any one of the 4 groups had a different performance when compared with the other 3. So it means that the system is able to identify homogeneous subgroups of low prognosis patients. That is the additional value, I think, with respect to Bologna criteria, because in Bologna criteria, all patients have a lower prognosis, but you cannot distinguish inside of the box subgroups of patients with a different pathogenesis. So this is a proof that, at least in my opinion, obviously, Poseidon works. So if I have 10 minutes, I would like to ask you to skip the next slides and to go directly to the section related to LH in controlled environment stimulation. So move a lot, because I removed this slide. This is just to prove that patients with hyperresponse have a higher incidence of polymorphism of FSH receptor in LH system. So group 1 and 2 Poseidon, in vast majority of cases, reflects the effect of inhibitory polymorphism of the LH and FSH receptor system. But I want to skip directly to the LH. Okay, let's go. Skip. This is to say that group 3 and 4 probably need duostim or other kinds of accumulation program. And so if you like to do it in the discussion, I will tell you more about duostim if you have experience that we can share all together. But I want to directly go to the LH section. So I think that in 1 or 2 slides we will be there. And this is what I will, next one, sorry. Okay, so I will go to the most important points. And I think that the LH, the use of LH is a good way for understanding how much is important to have a good classification of low prognosis patients. Because if we give LH in all patients, probably we run the risk of not perfectly understanding where it works and when it doesn't work. Or if we give LH in poor responders in general, we run the risk of not understanding if it really works. So I think that if we understand in which subgroups of patients exogenous LH, in particular recombinant LH, is more effective, we run the risk, we have a nice opportunity for understanding how we can really tailor therapies. So the first point I tried to address with you is what is the best way for understanding in reading a literature in general or designing trials to understand if LH is working. So I will go very fast in the next slide, if I can see the next one. You can see that we have an incredible information. We have a very good meta-analysis that has been performed in more than 8,000 patients. Huge, an incredible number of patients. More than 30 trials have been analyzed. And have a look to the next slide. What was the conclusion? The conclusion is that we cannot prove that LH is better than FSH monotherapy. The association of FSH LH is better. Why? Because there is not sufficient evidence in live birth rate. But let me tell you something. If you go to the previous, live birth rate is reported in 500 cycles. So we have the possibility of analyzing 8,000 cycles. If we want to have an information from only 500. So it is something incredible, because one thing is to say, I don't have sufficient evidence to say something. And a totally different thing is to say, I have the evidence that something doesn't work. In this case, we don't have sufficient evidence because only 500 cycles reported the live birth rate. We don't have sufficient evidence, but we cannot say that there is evidence that it doesn't work. But if you go to the next slide, I will show you, skip the next 2 slides, and go directly to skip this. Thank you. Skip the oranges and the apples. I don't need it at the moment. The next one, sorry. Have a look to the ongoing pregnancy rate. Ongoing pregnancy rate, meaning that you have seen the heartbeat. And if you are over 10, 12 weeks, the observation is available in more than 1,500 observations per hour. So 3 times more in terms of sample size. And there is clear evidence that if you stop your observation to ongoing pregnancy rate, the association of recombinant FSH and recombinant LH performs better, even in general population. So in literature, we don't see so crucial information because ongoing pregnancy rate doesn't as indicator. And we stop a very good possibility to say if there is no evidence looking at live birth rate. But live birth rate is very far in terms of time from controlled ovarian stimulation. So it's impossible. If you want to have an information about live birth rate, you need probably 5,000 patients per group. And the second problem is that, I repeat, it's too far from controlled ovarian stimulation. And the difference between ongoing pregnancy rate and live birth rate is 2%. Ongoing pregnancy rate is very representative of live birth rate. So there is no reason to say that the ongoing pregnancy rate is just mathematical exercise to say I trust one, I trust live birth rate, but I don't trust ongoing pregnancy rate. This is just my opinion. So I want to tell you just one, if you can go to the next slides, I want to just deliver a message that we have to keep in mind when we analyze literature. So look to just make one click. Have a look to this one click in the same slide, sorry. Have a look to this representation. This is the classical 2 cells, 2 gonadotrophins theory. If you have a look, LH works in TICA cells according to the classical system since the beginning of, continuously, since the beginning of the menstrual cycle, but at any given stage of follicular genesis. In TICA cells, androgens are produced, move to granulosa. In granulosa, androgens are converted by aromatase in estradiol, and the aromatase is under the control of FSH. So according to classical model, LH works in TICA, produces androgens, FSH in the other compartment. But we discovered something incredible in the last years. We discovered that many basic science studies proved this, and that LH receptors are also expressed in granulosa cells when follicles overcome 8-10 millimeters. The problem is that the granulosa cells is not involved in androgen production. So LH induces androgens in TICA cells, but it cannot induce androgens in granulosa. So we have to recognize that the same hormone plays a different role in a different compartment. And what is this rule? The rule of LH in this compartment is to support, totally support FSH activity, because they have different receptors, but in this compartment, they converge. So if at the post-receptor site, transduction mechanisms are totally convergent. So it means that if the FSH system is not perfectly working, because for instance, an FSH receptor polymorphism, inhibitory polymorphism is there, you can probably overcome this problem by giving LH in this compartment. On the other side, if LH is not perfectly working, because a polymorphism is there, or because the androgens reaction is lower for many reasons, for aging or whatever, you can probably counteract this lack by giving FSH or by giving exogenous LH. So the combination of both gonadotrophins in a good ratio is always able to counteract the lack in terms of activity of the same gonadotrophins or even of the other one. So this is important because what you have to keep in mind is that if you give LH at the beginning of the cycle, from the day one of stimulation, you are moving androgens in TICA cells. And if you move androgens in TICA cells, you are moving follicle recruitment. Why? Because androgens are very important for determining the expression of FSH receptor in granulosa cells. If the androgens are in the right window, the FSH receptor in granulosa cells will be in the right window, and the follicle will be more sensitive to FSH. But if you give LH in growing follicles on day 6, day 8 of stimulation, you are contributing to androgen production TICA, but you are helping FSH in steroidogenesis, in supporting paracrine local activity, in supporting aromatase activity. And another crucial, and now I need your attention, LH in granulosa cells is the main regulator of surviving of granulosa cells, because activating ERK AKT pathways, it determines the number of granulosa cells that have to survive, because LH is anti-apoptotic. So if you have adequate quantity of LH that nature put inside the system at that stage, you will have more granulosa cells surviving. It means that the granulosa cells will have better biological activity, will better regulate oocyte competence in last stage of maturation, and you will probably have a better corpus luteum after ovulation. ACG is good in supporting FSH in steroidogenesis, but nature didn't put ACG at this stage. ACG is not able to give anti-apoptotic effect. So if you give ACG, this is not proven by, there are no clinical trials to prove directly this, but there are many basic science studies to clearly proving that if you have ACG in the system at the moment, you are helping FSH only in steroidogenesis, but not in paracrine anti-apoptotic activity that has to be guaranteed by the association of FSH and LH. So I spend the last minutes, if you can directly go to the last point, which is the use of LH in the, so if you skip very rapidly, we can go there together. These are basic science studies, though I strongly suggest to read it by the group of Manuela Simoni. They are all the in vitro studies demonstrating, you can go, that the activation of pathways, G protein and cyclic AMP pathways are totally different if you compare the ACG, NA, and LH in the same granulosa system in vitro. If you can go on, and I go to just few clinical information that can be very good for you. Go on, because I have to go to conclusions. You can even go on. Just want to deliver the final messages. This is a nice way I use to say that LH and FSH in granulosa works together as moving a table from one room from another. So if the two guys are healthy and very strong, no effort is there. But if one of the two is weaker, meaning that the FSH polymorphism is there, the other one has to work more, or you need to give more FSH from outside. If the LH system is weak, meaning that the patient is above 35, for instance, meaning that the androgens are lower, or some polymorphism is there, you need more FSH for having the same effect, or you need to add LH. So if you can go to the next slide. Next slide. Okay, so what we did is we tried to understand if LH works in different Poseidon groups. So next slide will show you that if you consider a patient that in the previous cycle had less eggs than expected. So good ovarian reserve, but low sensitivity to only FSH. Next slide. Next slide. Sorry, I don't know what's going on. Thank you. Next slide. Next. This is the paper where we tried to, if you go to the next. Next. Group 1 and Group 2 Poseidon. Next. Next. This is a slide, the next one. This is a slide that summarizes a meta-analysis that we recently proposed, that if you take group 1 to Poseidon, meaning a patient with apparently good ovarian reserve that had less oocytes, was lower response to monotherapy with the FSH, if you add the recombinant LH, they have better performance in terms of FORT and even in terms of clinical pregnancy rate. So if you take the general population below 35 years of age, they don't need probably recombinant LH. But if you select patients that had less oocytes than expected in a previous cycle, or a higher consumption of FSH in a previous cycle or in the ongoing cycle, the supplementation with LH in terms of efficiency increases the length of the reduces the length of stimulation and increases the final results. Next slide. But let me tell you about the use of recombinant LH in groups 2 and 4 Poseidon, meaning patient above 35 years of age. Let me show you something that in my opinion is incredible. It's very nice and it's very informative. Next slide. If you only analyze, next slide, next, thank you. If you only analyze patients between 35 and 39 years of age, you can see that comparing recombinant FSH alone and recombinant FSH plus recombinant LH gives us a result, a significant increase in the ongoing clinical pregnancy rate in patients treated with recombinant LH. Next slides show you that this effect of improvement with recombinant LH is still present if you analyze all trials, including a patient between 35, the previous, thank you, between 35 and 40. So up to 40 years of age, it is clear from evidence that the association of recombinant FSH and LH improves ongoing pregnancy rate. But if you analyze trials, including a patient above 40 years of age, it is more difficult to see the effect of recombinant LH. The impact on ongoing pregnancy rate disappears. Why? It doesn't mean that it doesn't work. It means that the impact of low ovarian reserve, but what is important, the incredible impact of aneuploidies cannot is not counteracted by LH. So when you are between 35 and 40, you have still a good ovarian reserve, acceptable ovarian reserve, and the rate of aneuploidies is still acceptable. Okay, so if you give LH, you probably improve something in the cytoplasm, in the biological activity of oocytes, something probably at different level, and so probably you counteract the lack of androgens, which is typical of this window of age. But if you overcome 40, even modifying this aspect, the impact of aneuploidies is too high to let you know an effect of LH, because the impact of aneuploidies is too high. So it doesn't mean that it doesn't work. It means that if you want to see an impact of LH in patient above 40, you probably need a huge sample size. So I finished. If you can just show the final slides of conclusions that I will not read because of, let's go directly to the conclusion, because this is just to suggest some dosage of LH for stimulation. I can only say that if you work with agonist long protocols, please consider that the minimum dose of recombinant LH is 150, not less. You can use even 225 or more, but not less than 150 with the agonist. If you work with antagonist, you can even consider 75, but since the first day of stimulation. And I suggest, this is my personal experience, but it is also reported by some trials, in patients above 35, to move to 150 when you start the antagonist. So I really thank you for it. I apologize, the flow, the talk was not fluent, and I spent more time than attended because I couldn't, but I really thank you, the technical part technicians, because it was, I think, very stressful to follow me in. And in my final selection that I have on my PC, I dramatically reduced the number of slides. So it was very difficult to me on my side to skip and to go, and probably it took 20 minutes more than expected. But what is important is that we were able to manage our unpredictable low ovarian response. Thank you very much. Bye.